Okay, I think that's 10:16 and it's time for us to start. Welcome everybody who's joined us. This panel is why 5G will prove fundamental to improving healthcare. So if that's not the panel you were expecting to join, now's the chance to go somewhere else. But I recommend that you stay because I think it's going to be an interesting and very important thread. So thanks for joining. So I'm Adrian Smith. I'm here because I'm leading the health and social care stream for the West Midlands 5G programme. And as many of you I hope will know, it's the most prestigious and largest 5G programme in the country. Government supported, but also heavily engaged with industry and the public sector. A very important initiative which the region is proud to host. Before I tell you a little bit more about how the session runs, could I ask, if you haven't already done so, that everybody who's listening here mutes. And as we go through the session, if you want to ask us any questions, our preference, our very strong preference, is that you type those questions in the chat side of the Zoom system, and we'll be picking those up as the session goes on. Please don't hold back with your questions. We've got an interesting panel who are keen to try and answer some of them. So I mentioned that I'm leading the programme from West Midlands 5G, but I'm also a long-serving NHS employee. And it's important to say that because I'm a great believer that 5G will prove fundamental to improving healthcare and have been for a long time, perhaps even before 5G became a buzzword. And it's really fundamental to the direction of travel that the NHS and healthcare systems worldwide are trying to achieve. So before we tell you a little bit about the panel itself, we've got a very varied panel today, from frontline practitioners in the NHS to those who are busy trying to transform the NHS from the inside, from people looking into the NHS from the outside, trying to bring new and exciting technologies to bear, many of which require the connectivity that 5G will bring. And what we're going to do for the first half of this session is we're going to have, I hope, a fairly light-hearted discussion between the panel members. And as I introduce each of them through a short question, I'll ask each of them just to say a little bit about what their role is, rather than me try and attempt to do that at the start. But a quick bit of background. So it's only a few months ago that COVID wasn't with us. And even before then, the NHS and healthcare systems around the globe needed connectivity. Why is that? Well, it's because healthcare systems are under huge pressure. The clinics, hospitals, GP practices, as you'll hear a little bit later, are all under huge pressure. The load on urgent and emergency care departments is tremendous, as we all know. And for a long time, we've known that what we need to do is to change where and how healthcare is delivered. We need to give citizens the ability to manage their own health better. We need to help them prevent getting ill. And when they do get ill, we need to give them the tools to manage their own health better. And increasingly, those tools have to be digital. They have to be digital because the scale at which we're trying to tackle these problems. If we want people to manage diabetes, for example, then we need to get them to do that digitally, because only digital solutions reach out broadly. And of course, more and more people want to manage their health digitally anyway. So we need to recognize that. So that strong driver has always been there, but we can't make those things happen without connectivity. We can't give people the digital tools. We can't diagnose people in the community and the workplace without the connectivity to deliver those solutions. And what you're going to hear about today are some of the examples of where 5G is fundamental to making that happen, and why we're going to see healthcare transform quite significantly over the coming years, both where and how it's delivered. So that's a little bit about the background to the session. Just to repeat for anybody who's joined since I started, if you want to ask questions, please do so through the chat. You'll also see on the slide, and I should have mentioned this right at the start, that right at the end of the session, we're going to have a couple of questions on Slido, and there's a URL at the bottom of the screen, bottom left, for you to use. You can't just click on it, but please, if you want to answer the questions at the end of the session and give us some feedback, use that URL. So let's get into the session. First of all, I'd like to introduce Mike Emery. And I'm going to ask Mike, as a Commissioner of Healthcare Services, to introduce himself. Mike's, I know, predominantly in a rural community, and I'd like Mike, having told us who he is, to tell us a little bit about the challenges he's seeing in a rural area and how 5G is likely to help. Over to you, Mike.
Thank you, Adrian. Absolute privilege to be here this morning on this panel, and to welcome you all to this session. So, firstly, a bit about myself. I'm the Director of Digital Health in Herefordshire and Worcestershire's STP. That's a partnership of all the NHS bodies in the two counties, which includes our hospital trusts, our GP practices, and we work very closely with local government. As Adrian said, Hereford and Worcestershire is very much essentially a rural county. There are some areas of more of a sort of urban basis up towards Birmingham, and that presents its own challenges as well with regards to deprivation. But one of the things that I'm battling with regards to how we deliver healthcare in rural communities is that connectivity challenge. We've increasingly reached the point where several of our villages and market towns at the moment struggle to link up across the counties and provide information into their hospitals or other community sites. So during COVID, this has become an even bigger problem, or a more noticeable problem. And that's been a challenge for us. So we've had to work very closely with GP practices across the two counties to think through how they can link up with fellow clinicians in hospitals, particularly around remote monitoring. And that includes things like vital signs, information from patients in GP practices, and in care homes. And many of you will have heard of, would have seen some of the stories around access to care homes. That's also been an issue around patients and residents in care homes connecting up with families. We ourselves did a survey of our care homes, and many across the county did not have very good Wi-Fi connections. This caused us to have to put in extra booster packs and the like to ensure they could people could connect up with their relatives, but also clinicians. So it's those kind of challenges we faced. Hereford and Worcester is the fourth most sparsely populated county across the UK. We have an increasingly aged population, where we have to think through how can we support people to live more independently in different ways, and technology becomes the key. So we've hit a variety of challenges in our work, which has included, as I say, care homes connectivity, the inability of clinicians to connect with GP practices and provide information. But I also think one of the things we have noticed is the risk of vulnerable patients not having access to technological devices. And it's an interesting dilemma we faced in rural areas, in the sense that we talk a lot around digital inclusion, exclusion, and people talk about how people can be digitally excluded. Actually, technology and 5G has got the potential to link people up to health services more adequately and quicker, where they've been actually excluded from some of those health services. So we see 5G as being a big potential to help us with that kind of work. What I should say, what's been interesting during COVID is how we have used improved connectivity to deliver health services in a variety of places, from video consultations to iPads in care homes, and also remote monitoring. Just a few stats of some of the things that we've faced is before COVID, we were only doing 2 video consultations, GPs, 2 a week across our 80 practices. By the end of May, we were doing 5,000 across all our GP practices. Where there were difficulties were in those rural areas where we didn't have good connectivity, and 5G potentially could help fill some of those gaps and challenges we face. The other area is out of hospital care where we've got patients with long-term conditions. This includes particularly those with respiratory challenges or cardiovascular challenges. How can clinicians monitor their remote signs remotely and actually respond to some of the conditions they've got from a distance? And that's going to become ever more important when we start to discuss things around long COVID in the future. So as a commissioner, what do I think 5G could give us in the future? Well, I think very much it would allow us to have some real-time information flows. Importantly, it would give us better access to quality images and the availability. One of the problems we have is the lack of bandwidth around a lot of 4G and broadband. And clinicians, it's really key to clinicians that they receive good quality images. We want better access to information in different places around between clinicians. That's really important. And we also want to set up what we call community diagnostic hubs that will allow in villages and hamlets and small towns for us to undertake diagnostic work more remotely and away from hospital sites. And I think what's really important in rural areas is trying to reduce the amount of time people potentially undertaking journeys between hospitals and GP practices. And we did some work around the carbon footprint and felt that if we can do more outpatient appointments remotely, it's the equivalent to a small forest every year of trees that we could plant. So I think it's very important from that sort of angle as well. So I think broadly for me, 5G for a rural area could really reduce health inequalities, which is the responsibility of a commissioner. And I should just finish. We mentioned West Midlands 5G. Where I'm coming from is the sister project, if you like, to West Midlands 5G programme work is the West Mercia 5G programme up in Worcestershire, where we are looking at with DCMS in a specific rural area how we could connect care homes and GP practices up with an acute trust and actually really demonstrate the value of 5G going forward. So I'll hand back to Adrian.
Lovely.
Now.
Thanks ever so much, Mike, for a very comprehensive coverage there. I'm sure
Yeah.
there'll be some questions later, and also some of the care home pieces linking to, I know, what GP on the call, Stephen's going to talk about later as well. Thank you. So that's a perspective from inside the NHS. I'd like now to turn to John Vasey, who's going to look at it from a completely different angle. And I know that John is heavily involved in the use of satellite communications and connectivity and how they complement what's happening with 5G. So I hand over to John to talk about some of the things that they're doing within the satellite applications catapult and some of the applications they're focusing on. John.
Thanks, Adrian. Yes, so my name is John Vesey. I work at the Satellite Applications Catapult. We are one of 9 catapults that are dotted around the UK looking to support businesses in particular areas. And our catapult focuses on 2 major technology offers. One is around connectivity. So a lot of the stuff that Mike described is as a requirement, and for us it's about how do we make that connectivity ubiquitous so that it's available everywhere and capable speeds to do the things that we want to do, whether that's in a personal setting or in a business setting. So for that to work properly, we recognize that that needs to have a mixed solution or a hybrid solution between both terrestrial services like our fixed line broadband into our homes and onto our workplaces, 4G, 3G and the upcoming 5G, as well as non-terrestrial systems which are typically satellite based. And fundamentally what we're talking about there is designing systems where you have a single piece of technology in your hand, but it's able to connect to any or all of those connections when it's necessary. So you don't end up having 3 or 4 different handsets or mobile phones, one for your 3G connection, one for your 4G connection, and you have to work out which has got a signal. And then from a catapult perspective, the other thing that we also look at is geospatial solutions. And again, we look to blend both terrestrial and non-terrestrial technology to look at some of the things that Mike was also talking about in terms of some of the deprivation and how geospatial can happen there. But in order to really make the most of geospatial data, you need the bandwidth to be able to transfer the mapping, the routing analysis, and some of the additional analysis of the imagery, whether that's satellite imagery or map-based data from Google or otherwise, as well as the imagery that Mike was talking about, whether that's scans from patients or things that clinicians need in their hand immediately. So that's our role, and our role has always been about how do we integrate technologies. So it was great that we could be involved in supporting some of the work around standards before 5G became, as Adrian referenced earlier, before 5G became a bit of a buzzword. So back in the 2014, 2013 sort of time period, we were working away looking at the standards for 5G so that satellite connectivity could also adhere to those standards. And what we're seeing now with the advent of organizations like SpaceX and their launch around Starlink, OneWeb and their launch of their constellation, they will all be flying in what we call low Earth orbit, and will mean that they can adhere to the standards of 5G, so that if your device can jump onto a 5G connection, that can be either a 5G base station in your local area or 5G connection that can be handed over from satellite as well.
Thanks, John. Would you like to mention perhaps an example of some of the work that you've been doing in the health?
Yeah, absolutely. So, so for us, fundamentally, what we're looking at is the move, the step change from the government's approach for digital by default and the NHS's drive to go paperless, and moving that drive on to connectivity by default, so that everyone everywhere should have the ability to connect to do the things that they need to do, either as a patient, a clinician, or a commissioner. But as you say, Adrian, actually what we need to do is have, although we're somewhat agnostic about which particular care areas or care pathways we're interested in, because connectivity is useful across all domains, it's useful that we've got some examples as well. So we've been working in an area around strokes most recently, speaking to Mike about how we can utilise the Catapult's Health Living Lab and look at the methodology of changing the way strokes are dealt with, so that either they can be dealt with and data can be read by clinicians in a hospital without the clinician necessarily needing to be by the patient's side or by the data side, or extending that into an ambulance setting. And looking at how can that data be transferred and collected by a paramedic or an advanced paramedic practitioner, and then reviewed by a clinician either from the local patch or anywhere nationally. And fundamental to that is the trust and the ability to use the connectivity without the paramedic, the clinician being a telecoms engineer or a satcoms expert. It needs to just work when they turn it on, and they can get on with the job that they're actually employed for, rather than being a technical expert.
Fantastic. Thanks very much, John. I'd like to turn now back inside the NHS very briefly, and I'd like to go to Priyantha. And I know, Priyantha, that you're involved in an organisation that's giving support across a wide range of the NHS, and it'd be good to hear both about yourself and a little bit about what you're seeing and hearing from your wide range of customers about what they think about 5G and its potential, and whether the NHS has really got its head around what 5G can bring, the differences it's likely to bring as we try and transform. Priyantha.
Yeah, thank you, Adrian, and welcome to all of you to this session. I am Priyantha Jayawardena from Midlands and Lancashire Commissioning Support Unit. I'm part of the digital innovation team of the Midlands and Lancashire CSU. We are supporting various digital initiatives of CCGs and other partners we are working with. So in this particular situation, I am supporting Mike Emery, one of the previous speakers, to implement the West Mercia 5G, rural 5G project. So West Mercia 5G rural project is deployed around Ludlow and Tenbury Wells market towns in Shropshire and Worcestershire. So the main focus of West Mercia 5G rural project is to deploy 5G to support health and care projects in rural settings. So we have been working with several partner organizations within Herefordshire, within Worcestershire and Shropshire, to identify some of the use cases which is valued by health and care partners. So we went through a process including identifying the priorities set by 2 counties, as well as some clinical priorities. We had clinicians, care professionals, and academics from local universities working with us to identify potential use cases to trial on 5G. So the main focus is to of this testbed is, as I said before, concentrating on rural communities and what benefits can it bring, to understand what benefits or what difference can it bring to health and care professionals and patients in terms of delivering the day-to-day business. So if I move towards the kind of a customer expectations, so here the customers are not only clinicians and care professionals, it is, as Mike alluded, it is patients as well. There are huge expectations. Some of them are motivated through COVID-19 challenges to both all parties, clinicians, care professionals, and patients. There are huge expectations and kind of a customers want to change, but they are looking for a change because they know due to challenges of COVID-19, the traditional ways of working is no longer possible. So therefore, they are one of the key aspects they are looking is uninterrupted quality connectivity, so that they do their day-to-day business without worrying too much about technical issues. If you take a clinician who wants to have a consultation with a patient, sometimes they struggle due to bandwidth, low bandwidth, and poor communications. So they cannot really concentrate on their core business. So one of the key expectations from clinicians and patients is to have that quality connectivity so that the 10 minutes or 15 minutes of their consultation or discussion they can get on with it and do the core business. And not only the remote consultations, they are also looking remote diagnostics, the remote monitoring of patients. So that if I take remote monitoring, for example, if early warning signs coming from patients, the interventions can be done fairly early without them having to admit the patient to a hospital. So avoid unnecessary admissions, but help and support patients and customers as appropriate, and also engaging with carers. And so those are kind of key expectations and demands from customers. And also from the patient side, they could make use of quality video consultations to, especially under COVID environment, if they want to get in touch with their families, if the patient is living in a care home, if they want to get in touch with their families, they can have a reasonable video chat to their family and friends. And also they can sometimes have access to their patient record. They can take control of their data through various systems we have. So therefore, it is the expectations and demands are very, very wide ranging. Then if I move into the area where to see whether customers understand the difference. Yes, they do, but it is patchy. But the main point is there is a mistrust, because the experience so far, especially in rural communities, the connectivity was very, very patchy. So therefore, until we have to prove this to both clinicians, care professionals, and patients, that this is something they can rely upon. And then once we build that trust, I think we can make a huge difference to most of the care pathways we offer. It will be a saving to NHS. It will be a quality experience to our customers. It will be a quality experience to our clinicians and care professionals. So therefore, one of the key challenges for us is to make this happen and then provide uninterrupted connectivity with low latency, high bandwidth, so that clinicians and patients can get on with their core business. But I must also add the importance of change management when we are deploying this 5G and associated clinical pathway initiatives. We have to support not only clinicians and care professionals, also patients, to understand the changing requirements of the technology we introduce. So therefore, again, it's a challenge to NHS to support this change management, to make sure that our colleagues and our customers are engaging with these processes, and then eventually the benefit is delivered to wider NHS and taxpayers.
Lovely. Thank you very much indeed, Priyantha. As you say, it's always a challenge with any new technology to persuade the NHS to be confident and trust what we're doing. And 5G is no different. I wanted to just conclude by bringing it back to some of the things that are happening in the West Midlands with the West Midlands 5G programme and the projects that we've got underway in the region. Across Wolverhampton, Dudley, Coventry, across the West Midlands region. And then I'm going to hand over in a moment to Stephen, who as a frontline GP is going to tell us about how it actually feels on the front line to be delivering some of these and what he's doing as part of that. So in the West Midlands, we've focused on three case studies, 3 use cases so far. I'm going to briefly touch on 2 of them. So we're already heavily involved in the ambulance connectivity area, which John has already mentioned, where we're trying to support West Midlands Ambulance Service to utilise 5G to enhance both what happens at the scene when an ambulance treats someone at the scene, get better information, engage with the clinician at the scene, and then to enable the ambulance to, when it's transiting to a hospital, to engage continuously with wherever it's going to deliver the patient to, continue to access information, to continue to share that with the hospital and improve the whole operation of the ambulance. That's one of the projects we're involved in. We're also doing some exciting things around using 5G with diagnosis. So as a region, we want to be part of an initiative that's all about eradicating bowel cancer. And fundamentally, what we're trying to do is to get patients to carry out a complete procedure for endoscopy in the comfort of their own home. Basically, you swallow a small camera in the comfort of your own home. And we're using 5G in order to support and help train the patient to use that, the technology that's associated with that capsule, that camera, that swallowable camera, and using 5G to use VR and augmented reality in interesting ways to make sure that we can carry out a safe diagnosis in the comfort of their own home. And this is really important in a post-COVID world. Nobody wants to go to a clinic. Clinics are difficult to disinfect anyway, so if you can do things in their own home, it's a really good example of how 5G can support a diagnostic process. But I think the big example, which I want to now hone into with Stephen, is all around care homes, and we're about to see, I'm sure, hope not, but the view is we're going to see a second wave of COVID, and care homes once again will be one of the places that bear the brunt of what happens with that, unless we can use connectivity to support a change. And Stephen, as a GP, is at the heart of that. So Stephen, if you have a few minutes to talk about what you're doing and how it's working and what the reactions are.
Fantastic. Thank you, Adrian, and welcome everybody to this session. So my name is Stephen Katabi. So I'm a frontline GP, as been mentioned, working here in the lovely Lake District. And I have just over 14 years experience working in the NHS. And I'm also a director and co-founder of a company called Techie Hub Solutions, which I'll mention shortly. What I want to do is kind of paint you the picture, first of all, pre the technology, actually what happens typically in care homes, particularly in relation to GP services. So you may not know, but as GPs, we provide a very vital and critical service to care homes. Care homes house some of our vulnerable members of our society. A lot of them are extremely frail and they have long-term health conditions. So as GPs, what we do is we're usually the first point of call. So if a patient's unwell or the staff in that care home are concerned about anything, they'll usually contact the GP. So what we do is we either provide some advice via telephone, but most of the time we're doing face-to-face visits. Now, as I said, this is a really vital service we provide, because what happens when you don't have a dedicated GP service is that you'll have an increase in the number of unplanned hospital admissions. So care home staff typically do not have the necessary sort of clinical experience to assess whether a patient is unwell, whether they need to be admitted to hospital, etc. And as a result, often you'll have a lot of admissions, unplanned admissions to hospital. And this actually costs the NHS billions of pounds a year. And we know from small studies that have been done that if you have a dedicated GP service in a care home, you could reduce the number of unplanned admissions by up to a third. So now you add in COVID, and what's happened with COVID is we've had, first of all, huge number of deaths in care homes. What we noticed also was that patients were not just contracting this virus simply from going from hospital to a care home, but also it was the healthcare staff who were coming in to those care homes who were passing on that infection. So it's really, really important that we have a solution that will result in a reduction in the community transmission. So the question, how do you do this? Well, technology is the answer, really. So what we do is we provide diagnostic devices to care homes, which will allow clinicians, typically GPs, but there could be nurses as well, to provide remote healthcare. And what I mean by that is, that we can, as a GP, I could be sat in the GP surgery and I can see a care home patient, and I can do a number of things. I can obviously see them via video link, but also I can conduct a number of examinations, up to about 10 examinations. I can listen to their heart sounds, I can listen to their lungs, I can look inside their ears, I can look inside their throat, I can look at the skin, I can have access to all their vital signs. And all of this is being done remotely using technology and critically having great connectivity. So to tell you a little bit about some of the projects specifically that we're doing is we've got a device called the Techie Hub. And the Techie Hub does exactly what I've just described. So it allows that clinician to see and examine a patient remotely. One of key advantages of a GP mentioned to me that they're able to conduct what we call virtual ward rounds. So they will log on to the device. The healthcare staff in the care home will then log on as well at the patient end. And the GP will be able to see patients, examine them as and when is required. Now, one of the tragic things that's happened with COVID is, when patients die in a care home, as GPs, we will normally travel over there and see them and assess them, and also, decide whether or not they need admission to hospital. Obviously, if they're passed away, we are involved in certifying that death. You can imagine now that care homes having pretty much shut their doors to the outside world, it can be very difficult for us to make that assessment. So what our device has enabled these doctors to do is actually to do a death certification, so they can listen to the heart sounds and breath sounds and all those things using our technology. So really vital piece of that puzzle, as we discussed already, is good connectivity. We're reliant on the technology in order to listen to heart sounds and breath sounds. So if you've got a poor connectivity, then that becomes extra difficult. So we see a huge benefit in 5G. I know my colleague already mentioned about low latency and high bandwidth, and that is really, really vital to enable us to do what we do.
Lovely. Thank you very much indeed, Stephen. And I know that in the Midlands, you've got your devices out in Dudley, in Wolverhampton and Coventry at the moment, and that the feedback from GPs, patients and staff alike has been exceptionally positive. And I've noticed some of the questions coming through about patient reaction to it. And I know that patients have genuinely, wherever you've gone, have been positive about this.
Yes.
So thank you very much for the panel. That leaves us with plenty of time to answer some of the many questions that have been coming through. I can see some of them on the screen, but Leslie, have you picked some exciting ones out for us?
Oh, I hope so. Yeah, I'll go straight with the linking to what you just said. And there's two similar questions, so I'm going to tie them together. One is about stakeholder groups, saying how do they react differently to the potential that 5G offers, and that's looking at it from both perhaps the clinicians, patients and commissioner view. If I can link another question, which is actually feedback from patients in care homes. How do they react to seeing their GP or accessing their GP remotely rather than face-to-face, and what's their feedback? So two interlinked questions for you, Adrian.
Thank you. So I'll turn it upside down and go back to you, Stephen, first of all. So in the care home environment, what's been, and I know the pilots you've got are all over the country, so what's been the sort of reaction from patients and staff?
Yeah, very, very good question. So interestingly, initially we assumed that because obviously the majority of the patients in care homes are elderly, that we thought they may not react very well to this sort of sudden change in new technology. But the opposite has actually been true. We've received positive feedback from the patients, because really what they care about is access and how quickly can they, if they have a problem, how quickly can they get access to that clinician? And lastly, can you solve the problem? So a really good example, we've had a patient in patients in Norfolk who saw the GP remotely, and almost all of them said this exactly the same thing. Well, it was great that I was able to see the doctor that I've seen before, but he was able to solve my problem. You know, that could be anything from simply wax in their ears, a chest infection, etc. What they really, really care about is, can I have that access, and will the clinician solve my problem?
Okay, thank you. And I guess it depends a little bit, the answer to the question, on what the solution is one's putting in. One can see the immediate benefit in a care home, and particularly in a COVID environment, but it's not always so clear in other areas. Mike, is there anything I can ask you to add to that from other aspects?
I mean, interestingly, we've in the last couple of weeks done a survey of patients using some of the remote monitoring technologies, but also video consultations, and the response has been overwhelmingly positive. Primarily, the expectation that actually the rest of, if you like, the world and other sectors have engaged with the digital age, and the NHS is often lagging behind. So the impression that we've had and the feedback we've had from a range of patients and users is, bring it on, really. Let's explore some of these technologies. The big feedback and the challenge posed has often been around connectivity, and concerns raised that in some areas they could be excluded because they haven't got the connectivity. So again, going back to 5G, is the ability to enable that or lever that for those areas that haven't got the quality of connectivity that you might get in other urban areas like London, for example. So I think, from my perspective, it's only been positive from the feedback we've had.
Okay, you gave the statistic earlier on, Mike, about moving from 2 video consultations to 5,000.
Yeah.
I think a lot of people would imagine that the poor patient has had their arm twisted into doing a video consultation instead of a face-to-face, but that's actually far from the truth, isn't it? It's driven often.
It's driven. It's far from the truth. A lot. And it's been interesting. I mean, that was at the height of the lockdown. I mean, there's been a push. We've now introduced more face-to-face. I mean, who knows where we go in the next few months. But we've still maintained, a high level of video consultations because that is what the patients wanted. So now they've got the choice. There are still people out there that still want the opportunity to have that video consultation. And actually, often, it's allowed them to have a quicker appointment with a GP because they can access the service. So I think everybody's gained, and we should also think through the fact that it's also allowed some clinicians in this time to work at home, and there's benefits around workforce development and quality of life for them as well. So I can only see wins all round.
Lovely.
Kind of links to some questions here about COVID, actually. So it's about how, a couple of things is, has COVID accelerated the adoption and rollout, which I think in a way you've answered a little bit, but perhaps you might want to expand on it. But also, has it helped sell the benefits of digital and 5G technology?
So I'll go first on that one, if I may. So unquestionably, COVID has accelerated a whole raft of things across the NHS. It's a tragedy in some ways that it takes a tragedy to galvanise some of the changes that we've seen. And if I just hark back a little bit to one of those projects we're doing in the West Midlands 5G, where I talked about the capsule endoscopy piece, we've been trying to persuade the NHS for 5 years to roll out a capsule endoscopy solution across England. In Scotland, they've managed to do it, but we haven't managed to do it in England. As soon as COVID came along and COVID hit the clinics, and the need to disinfect clinics went through the roof, and patients felt they didn't particularly want to go to clinics, as soon as those drivers come along, then the barriers start to fall away, and suddenly we're seeing a rollout of thousands and thousands of capsules across England. So COVID has definitely enabled some change, and many of those changes are just in the area that we're talking about, where if you're going to make them happen, you need the connectivity, you need the 5G connectivity to make it happen. So COVID's been a big driver. Does anybody want to add to that? John?
I guess just to challenge that somewhat, as maybe as the outsider on the panel, I think what we need to be careful of is that, yes, a lot changed as a result of COVID. You know, Mike gave a great example in terms of the remote consultations, but already we're starting to see different places starting to wonder what balance should there be between remote consultations and face-to-face. And actually, I think it comes back to what Priyantha was saying about the change needs to be managed in such a way that it's actually a lasting change and not we're trialing lots of things in lots of different locations, but actually very few of them stick and last. And I think as an outsider, that's one of the things that I find the biggest challenge engaging with the NHS is not just doing the trial and proving the case and proving the benefit use case for whether it's 5G or another aspect of connectivity, but how does that embed and make the lasting change that we know it will do in such a way that it becomes an invisible technology. And actually to the previous conversation about, you know, patient advocates and patient engagement, as we've heard from both Stephen and Mike, patients don't really seem to care what type of connectivity it is if they can be shown the function of that connectivity, whether that's an ear, nose and throat exam, or whether that's a death certification, or the ability to just see their loved one in a care home. I think that is the focus of what they want to be engaged with and engaged upon, rather than, by the way, this is how 5G works, and are you comfortable with the standards that have been agreed at an international level for 5G?
Yeah, I think that's a really good point, John. And I think those of us, you open that with somebody from the outside looking in, those of us who have been embedded in the NHS for many years know that we love a good pilot. We're very innovative inside the NHS at piloting new technologies, but it's always hard to do what you said, to scale it, to get it embedded in the fabric of the whole environment. And what's happened with COVID is, you know, money has been released for lots of things, lots of pilots again. How do you, exactly as you say, how do you make sure that what we do here is sustained long term? And if it's in the case as Mike described with the video consultation, if the patient drives it, that's fine. But in other areas, we really do need the clinicians to say, I want this to carry on long term.
Can I just add one thing as well, in response to John's point there? One of the benefits that that we sort of emphasize a lot to clinicians is that, look, the technology does not replace the doctor, and this is often a fear, particularly from some GPs, but also sometimes even from care homes. They worry that, oh, as a result of this new thing, suddenly we're never going to see a doctor again, and that's not true. What we're doing is we're looking at the system as a whole, and we're saying, look, this service, face-to-face, remains the gold standard, okay? And I think it's important that the clinicians always remain in control, certainly about when this service can be used and when it's not appropriate. I think certainly as a GP, I feel like I'm in control. So I know that sometimes it is appropriate for me to use video, but actually it might be easier to use the telephone. And sometimes it's actually best that I go and visit the patient. And that's really up to the clinician to decide. And I think the technology isn't there to replace the clinician. It's actually to make their job that much easier. So, you know, typically, if I do a visit to a care home to see a patient, that whole process from getting into the car, driving there, seeing the patient, coming up with a diagnosis and treatment plan, and then heading back to the surgery, that whole process could take over an hour. Now, if I'm at the surgery, however, and I'm seeing a patient who comes into the practice, that takes 10 minutes. So you can see, certainly from the GP's perspective, that there's a huge efficiency saving that we could make if they have access to technology and they can see these care home patients without having to do the traveling. But also you need to make the case from the patient's perspective and say, well, look, what's the benefit to you? Well, certainly in the context of COVID, what we're trying to do is reduce that community transmission. So it's actually safer, that I'm not coming in and giving you any type of infection that I may be carrying. But also, again, looking at the system as a whole, you need to make that case to the stakeholders like the CCGs and say, look, actually, we can reduce hospital admissions, which is a huge expense to the NHS. So I think you have to make that case. It's not just a fancy bit of tech that everybody likes and then suddenly they disappear off. This is beyond COVID. This is effective for everybody involved.
Stephen, I'm going to leap in there if I may, and before Leslie gives another question, because a question's just popped up, which I'm afraid caught my eye, which says, Stephen, what you're talking about here is the clinician deciding, and the concept in the NHS should be about patient-centric and what the patient needs. And how do you get, I guess it's about that balance really, and it's different with different groups of patients too, I'm sure. So not putting words into your mouth and answering the question for you, but I know that, a different spectrum of patients, some patients are really strongly want to have that joint management of their the healthcare. Some patients in care homes, some very frail and elderly people may not be in the position to have that. But what's your answer to that patient-centric piece?
Yeah, I think certainly we're always practicing sort of patient-centered care. When I say clinicians deciding, I think what happens in reality, actually, typical example. So a patient in a care home becomes unwell. So the staff are concerned. What do? They will get hold of the clinician involved, the GP, and say, look, I've got this patient, they're unwell, what do I do? Do you think it's appropriate for you to just give me advice over the phone? Actually, do you think you need to come and see the patient face to face, or can we do all of this by video? Now, the care staff, they don't know that because they're not adequately trained. Equally, the patient doesn't know what the best method of healthcare delivery is. So as a clinician, I have the experience, number one, but also I'm looking at the whole system as a whole. So I'm looking at what's best for the patient, first of all, so it is sort of patient-centered because that's the most important thing. But then I'm also saying, well, how do I manage the time? Because I may have 15 other things to do, but there's also this patient, and then there's other patients that I need to see. So I need to be, fully aware of what's going on, and then try and utilize the time best. So yes, that's what I mean by when.
Okay, all right, thank you. I'm conscious that there's only about 6 minutes left, and if there are some questions that have the 5 and the G in them.
I've got a couple actually. We have only got a few minutes. So before I ask you the question, a quick reminder, if people could leave their thoughts as well on the Slido. So that's just a quick reminder. So the 2 questions, Adrian, which I'll let you determine what you can fit in, and I think they're interrelated, is about what's the added value of 5G over 4G is one aspect. And the other question, which is kind of related, is sort of related, is about how you describe and explain the benefits of 5G. And I think Mike and Stephen just now talked about real-time quality images, etc. So those are the 2 interlinked questions I'm throwing your way.
Okay, so while I let the panel think before I decide who I'm going to feed that out to, I mean, obviously the standard and correct answer here is about the features of 5G. It is about the speed, the bandwidth, the lower latency that enables the things that Stephen talked about. If you want to have a consultation where you can see the patient through a video consultation, at the same time as accessing a patient record, say, at the same time as getting the information through that Stephen talked about, the heart monitor, all of those things all happening at once, and you want it to be reliable and not fall over, then 5G is the route to that. But let me ask for a better and more comprehensive view. Priyantha, would you like to add to that?
Yeah, I think the kind of picking up from Stephen's answer, because clinicians have certain toolkits at their disposal to decide what is best for the patient. And then in consultation with patient, in agreement with patient, they will utilize their toolkit, most appropriate tool. So I think 5G will enhance the capability of their toolkits. 5G will enhance their toolkit altogether so that the efficiency can be introduced. A patient can be kind of seen quickly. It doesn't really, the surveys Mike and Stephen mentioned, patients are really don't worry too much about whether it's a face-to-face consultation or whether it's a remote consultation. What they need is the kind of a quick attention and resolve their problem. The key benefit of the 5G, as I can see, is it will enhance the toolkit available to clinicians and professionals to help out patients swiftly to resolve their problems, because 4G has that capability, but sometimes connectivity is patchy. So therefore, clinicians or patients are worried about, will this communication channel break now? So they have some doubt in their mind. So therefore, the key benefit of 5G, I think, is the kind of a hopefully uninterrupted quality communication channel, which will allow them to do their core business.
Michael, John, want to add to that, or?
Yeah, happy to come in, unless Mike, you want to go first?
No, you carry on, John.
So for me, I think the evolution from 3G to 4G was typically faster connections and slightly higher bandwidths. 5G was a real chance to change the way that it was a generational change between connectivity. And actually, it's great to see that the international community has taken that chance. So although there is the Kevin Bacon's 5G, where it is very much about the slightly faster download speeds for my personal use, there are a number of additional aspects to 5G that are inherently secure, that have opportunities for healthcare in areas like how do we connect devices to other devices without needing a person in between, without necessarily needing them to connect to the internet at all points in the journey. So it's typically talked about as Internet of Things. It used to be talked about as machine-to-machine communications. There's various buzzwords that it's called, but 5G has a specific capability around being able to connect devices to each other. And it's not something that unfortunately Kevin Bacon will be advertising anytime soon, but it's fundamental to the ways in which we want to connect to tools that do remote monitoring of patients in their setting, whether that's a home or a care home, and can present data to themselves, to their loved ones, and to clinicians, commissioners, and those looking after their care, so that they can be seen both as a patient and as a person, by having data that they can own and that others can engage with where it's appropriate to do so. And I think those are the sorts of things that 5G will enable. Now, Priyanka's absolutely right. Some of the challenges that the general public will feel about 5G will be about connectivity and how quick their speeds are on whatever device they're connecting to. And that's partly because the way that 5G is being deployed so far is an enhancement to 4G connections. So you have to have a 4G connection first, and then if you have a 5G compliant device, it can then jump across to 5G. There are some instances where there are standalone 5G networks, and our Catapult happens to have one of them. It's a shameless plug right at the end.
It's okay, we'll have a shameless publish for the West Midlands 5G as well, because we have them too.
Exactly. So there's plenty of research going on, and actually what's fascinating is that the UK is leading that research in various different locations to see how you can have a standalone 5G connection, and how that would interface with mobile network operators, private networks. 5G allows for, if an NHS were to take a decision at Mike's level or at Priyanka's systemic level, 5G allows for a private network to be created so that you could have all NHS devices on their own private network, run by and for the NHS, using NHS facilities as masts and facilities to bring out the network. So there is an opportunity to do 5G in a fascinatingly different way to how 3G and 4G has just been
Lovely. I'm going to have to stop you there, I'm afraid, John. Sorry, we're a minute over our time. Thanks to all of the panel for an interesting discussion. Thanks for everybody who's listened in to it, and thanks for your questions. I'm sorry we couldn't answer all of them. There are many more interesting ones in there. Do the Slido feedback for us so that we can decide if and how we would repeat this in the future. And thank you to everybody for being involved. Enjoy the rest of the event.
Thank you.
Bye.
Thanks all.